So why don't you tell us a little bit about why we're doing this today?
Sure. So this is a young woman who actually has hemorrhoids, and patients who either failed banding or they have not failed banding, but they have pretty significant symptoms where the GI physician may feel like they are not a good candidate for banding, like they might need multiple bands. Then we often get patients referred for hemorrhoid embolization. So she's undergoing a hemorrhoid embolization.
Very good. So the first target for hemorrhoid embolization are branches of the superior rectal artery. And therefore, you have to get into the IMA to start.
You got it.
So what are some challenges about the IMA?
Okay. So one thing that's important is imaging your aortogram here like we just did and getting into the IMA. RAO projection.
RAO?
Yeah. RAO typically arises here, as you'll see it, at L3, L4. There's really good imaging on her, but this might be just a little bit higher. You'll see hers arise at L2, L3.
Mm-hmm.
So we tend to use a reverse curve catheter, like a SAS, to get in.
Yep.
So once we get into there, then we'll go out of our RAO and we'll just go to an AP view, and you'll see it. We'll raise the table and get as much as we can on her. We won't be able to see now in this single view here all the way down to basically the rectum. We'll see the superior rectal arteries on this run, which you'll see popping up right here in a second. Let's see these.
Bifurcation of the superior rectal.
Yep. So we'll see that bifurcation here, as you can see, of the superior rectal branches. There's two main left and right superior rectal, but oftentimes there's four most commonly. So anterior and posterior, or right and left.
Yep.
The only reason we have this image is really to get our microcatheter down to above that bifurcation, and then we'll do our.
So you use this as a roadmap.
Yep.
To get down.
This is service over.
Selectives of each of those.
You got it.
Yep.
So we're going to work our microcatheter down. We're just getting that set up right now.
A TruSelect, huh?
A TruSelect.
2.0 French?
2.0. So nice, smooth hydrophilic catheter. You've got a lot of experience with this. Why don't you tell me about your experience with this catheter too?
Well-built catheter. It works really well. One of the unique things about TruSelect is that it comes in the 175 cm size. Now you don't need that for this case because this is a groin access for hemorrhoid embolization, but that is a unique characteristic of TruSelect.
Yeah, I mean, I like that. That advantage, of course, in these individuals that you're going radial on are really important. I tend to not go radial very often for hemorrhoid embolization.
Yeah, why not?
Yeah, it's interesting actually you say that. There are sometimes, just like in those distal PAE cases where you need to get really down distal internal pedal, for example. You can pull that wire back to when you have a chance. We have to go here very distal too, right? So when we get down to our rectal branches, we're going below the level of really oftentimes the pubic symphysis.
Yeah. So
when we go that distal, even in individuals who are shorter, it can be challenging. Now the 175, of course, will overcome that challenge.
So I guess one advantage perhaps radially is the angle at which the IMA arises.
Yes.
Maybe a little bit more favorable approaching from a proximal aorta.
Absolutely. So I'd say coming from radial, what's nice about that is you can bring your MPA down beyond that left colic branch. And so you can get very good imaging, 5 French imaging distally or 4 French. And then when you get that imaging, of course, we'll talk about really the contribution of middle rectal arteries. And so that can be really advantageous.
So at this point, you're not looking at any of that quite yet because you're just using this to get down into those arteries. And then you're going to shoot a more selective and look for anastomoses of that sort.
You got it. You can see our fathom wire is down ahead of our TruSelect. And we'll just bring that back here out of this branch. Nice about this catheter too is, even in these branches here, it's oftentimes very delicate and easy just to advance that catheter by itself without a wire.
Yeah,
so
absolutely.
That can be really nice.
Sure is.
So your experience with sort of 2.0 catheters and this wire, tell us a little bit about this wire and why you like this one.
Yeah, Fathom tends to be my first choice of wires. Reason being is because of the shapeability of the tip and the ability to reshape it. So you can give it a custom shape, and if the situation changes or you're headed into a different branch that needs a different shape on the tip of the wire, you can reshape it.
Right.
I appreciate that a lot. And then it's just, it's an 014, it's nice, it selects a lot of branches. Now sometimes that's annoying because you're selecting every little branch as you're going. but other times that's what you need to get into where you're going.
Absolutely. Well, it's interesting. In this particular case here, as you can see, so we've now done our angio here at that bifurcation of right and left superior rectal. The dominant supply to our hemorrhoidal cushion here, as you can see on the left, right? So that left branch that's going below the level or at the level of the pubic symphysis. It does have a little inflow to it, which makes me suspicious there could be a little bit of middle rectal inflow, albeit we don't see any retrograde filling of the middle rectal branch. Yeah. So we'll definitely want to target that artery, but as a female, she typically has these smaller size arteries that we identify, right? I just happened to take the right because it went to the right first. And then we're going to use the wire and go further distally down that right superior rectal artery.
So on your previous angiogram, you commented how we were only seeing 2 branches of there's usually 4 branches.
Exactly.
So do you think in this image that proximal branch is actually the other two branches? It looks like they may be extending downward towards them. That proximal branching point.
Absolutely. Yeah. So once you're right, 4 centimeters down each of those main right and left trunks, then there are branches that go right down the middle that are probably posterior branches as well. And so what we'll do here is we want to get down the larger of these.
So based on this image, your plan is to go down to both the right and the left that are headed down distally.
You got it.
Even though the left is probably what is really supplying the hemorrhoids.
Left is probably the more dominant, but if we don't take care of both of these, then her recurrence rate would be very high. So first thing I'm doing here is just going around distally here. With it, 2 French is really advantageous in someone like her because her vessels are actually natively small. These are fairly small arteries. So once we get to this position, if we're identifying the cushion well, the hemorrhoidal cushion, which hopefully we'll be able to see on this run here, and see that branch going down.
Way down there to the pubic symphysis. Yeah.
You'll see a little blush here. Yeah. So you'll see the blush of the rectal mucosa, but then all the way down by the pubic symphysis, you'll see us actually filling the hemorrhoidal cushion. So at this point, question becomes, do we go further down here, right? Or do we deliver our therapy from here?
There's your reflex, right? Into the middle rectal.
Into the middle rectal. Side. You got it. So via filling either branches of like you typically either internal pudendal or obturator branches. So what we'll do here is sometimes we'll make an attempt to go around this bend and go a little bit further distal. We can see.
Distal to be anastomosis?
Exactly. Well, not even so much. If we can go distally, anastomosis, great. There, on this case, you can see there's just so many small, channels to get past. But if we can, it might be nice to get beyond that first loop into the vertical segment of that artery. Right. So, we call that the corpus cavernosum rectum. Corpus cavernosum rectum. You're really calling out a challenge in this fire.
Challenge to that. So that's a different cavernosum than what you and I are usually doing.
Yes, exactly. That's a completely different cavernosum. So we'll see how this wire does. I'm pretty confident that torque device moves.
Usually a little twirling with the wire will do a few things.
Yeah, actually. We'll see. All right. Yeah. And honestly, for this, we're just looking to see it's going on a small branch. May not be a reflection of the wire as much as it is just a reflection of anatomy here, I think.
So there's I guess one of the papers talks about if you see the anastomosis like this, you just particle embolize until the anastomosis is no longer visible, which is a little bit of an interesting technique, but that's what the most recent paper in JVAR, that's what they described.
Yeah, I tend to use both, as you know, particles and coils. So with that, technique, I would say we are oftentimes able to get distal embolization there at that cushion, because that's what we're looking for, right? My fear of just using particles, of course, is then the amount of particles you need to achieve stasis. And in the most recent randomized control study that looked, or comparative study that looked at different size embolics, it looks like no matter what, it's still favoring going towards that mucosal vessel. So.
And what happens here if you just push the catheter with the line?
Yeah, so try that here and see. I think that it looks like no matter what, it still wants to go that medial mucosal branch. And rather than honestly have spasm and and go for something that can be more distal here. I'd say we
You're gonna
park
pour it
here.
Yeah.
We will. I'll take a 2 millimeter coil.
2 millimeter. Gotcha. 2.4 or 2.6?
2x6 should be good. First thing we're going to start here is while we're getting that coil ready, we're going to start with our particulate embolic.
Yeah, so what are we using for embolic today?
So we're using B block today, and we're only going to really deliver just such a small amount. And the reason why we use a small amount is we just fill really the hub and then a little bit of the catheter.
So you're not even pushing through all the dead space. You're just putting like a 0.1 or 0.2 cc's.
Absolutely. Yep. Just filling that hub, and, like you mentioned, 0.1, 0.2, and then delivering an antigrade. In here, we're using 300 to 500 size. Typically, we'll use even a size a little bit larger.
5 to 7.
5 to 7.
600.
Yep. Somewhere around 600 seems to be an ideal size. Our challenge in her actually is that the reason the size works out well is because the size of her
Smaller vessels.
smaller vessel. So it's really not a one size fits all. So after we've got that through,
Personalized medicine.
there you go. So
All right.
Now.
Drop the coil here.
ready to go through our coils here. So push that in.
So which coil did you select?
Yeah, so we're using the Boston Scientific interlock coils. This is a 2 millimeter coil by 6 cm in length. And so it's nice here. We'll be able to deliver this coil here right in there, and we'll hold some forward pressure on it. So obviously that coil doesn't come back on us. And let's see here. You can take comes as you know in a casing, right? And then once this coil comes out, it's not retrievable.
It's detachable but not retractable.
You got it. You got it. So here with that pushability, what's nice is despite that acute turn at the IMA, it's still able to keep its shape there.
There it goes. Look at that.
And it looks like even the coil wants to take that preferential turn, and down towards what our branch we wanted. What's happening is nice now is as bringing it back, it's packing really well.
Nice and soft.
Nice and soft. So you can see the retractor. I'll just move it back and forth. You can see that little dark spot is the retraction portion of the coil. It's coming back, and that's going to come out.
To say the
We'll
magic
take
words.
one more maybe. We'll use a 3 here. We'll back this up with a 3. What are those magic words?
Peter Pattison. I don't know.
Peter Pattison. Peter Pattison. That was nice. I like that. Sorry, what are your thoughts really wholly on, let's talk about sort of hemorrhoid embolization in the space?
Yeah, so it is I think it's just exciting that there's another option that's available for patients that doesn't involve a surgery. It doesn't involve banding, which although it sounds pretty benign, pushing a band around vessels in the rectal region is not as benign as it sounds. So just to have another option available that's minimally invasive with very little discomfort associated with it I think is really exciting for patients.
Yeah, it's really nice. I will tell you, patients who've undergone previous banding who undergo something like this, they always remark on how easy this is to go through compared to, honestly compared to what they went through with the banding. And so that's been something that has been really nice to hear them say. So we deployed a 2 millimeter, then a 3 millimeter. You can see despite being in probably a 1.5 millimeter vessel,
Right.
it was able to coil well. Following this, we typically will do a run, make sure that vessel's occluded, as you can see here,
Yeah.
and then I'll check to see is anything else really supplying that. And on the right side, none of those, on the right side, you'll see there aren't any other branches that are going down. It's nice. And then on the left side, which we'll look at next, you'll see here, we'll go over to the left. And
So what are you thinking about that anastomosis at this point? Are you going to leave it as is? Are you going to go take a look at it?
yeah, so it's a really good question. So at this point, I probably will not take a look at that anastomosis. In order for us to really go treat a middle rectal in the same session of treating from the superior rectal, we'd have to see it as a really prominent inflow vessel. And we'd want to see it really perfuse an area of tissue of the hemorrhoidal cushion that we couldn't get to from here, either with our beads, because meaningfully, right, these patients will get a significant, back again. So, meaningfully, we'd like to see them, honestly, have some change in symptom with respect to like a failure of therapy.
Before you go back. Yeah.
Before we go back.
Yeah.
That's how easily we got distally there with that.
Now, what about coiling? So when you coil, is it standard? Usually use 2 coils in a vessel. Is that kind of
typically I'll use 2.
Standard?
Yeah, I mean, as you know, patients of the interventional radiologist, if we waited a minute, we probably would have gotten some.
But it's impossible for us to wait because that's the nature of our specialty.
Exactly. So what do you think of this one? It's
Well,
a
now
nice.
you're really seeing a good anastomosis there.
Exactly.
That actually looks like an inferior rectal.
Yeah.
That's
So that looks really nice, and I think we're distal enough here. Again, if we get beads in here,
yeah.
we should be
Shut that down.
we should be able to shut that down pretty nicely. So I'll go back and grab our beads. So I'll take our clean syringes over there and we'll get our beads right here. And like I mentioned earlier, we're just really getting a little bit in here. Flush these through, and after we get these through.
It's interesting from a place where we've done a lot of prostates. We always see these branches, the middle rectal, the inferior rectal, all the time on our runs, and we kind of just think very little of them. Because it's prostate, you don't care about it unless it's in your way and it's going to be an anastomosis. But now these are big players in the Embo.
Yeah, you're exactly right. I mean, it's funny. These small little channels, right? 2x4 sheet. So we're going to use a 2x4 coil. It's going to be very similar. I'll probably actually use a 2, and then I probably will use another 2 because this is a very small branch. And we could here try little patients, give it 2 millimeters and see.
You want to try one and we can talk for a little while?
Yeah, exactly. Absolutely. But so back to all of these branches and getting into these. I will tell you in just a case last week, similarly with a 2.0 catheter, there are a lot of narrow, channels here. I think we could get beyond an anastomosis like this with a 2.0 catheter. We have gone from superior rectal to middle rectal branches via the IMA. Mm-hmm. So I am confident that this catheter could do that if need be. Yeah. If you do notice one thing here on the field R, you'll notice that one thing you find interesting is despite having this catheter, because of the amount of dead space I have eating up my base catheter, I don't really have a lot of microcatheter left. So
what length? That's basically based on the length of your sauce. Right?
Exactly. So this is an 80 cm catheter base. So with that 80 cm, but now I'm returning another, if you will, at least 40 cm going down towards this branch.
Right, and this is a 130 true select.
Yeah, and so exactly. So 155 would easily be, I'd say, a comfortable length to use. I will, we'll pull this catheter back here a touch. I'd say let's go for one more. Coil. So that's about how long. That's about how long I'm kidding. All right. So let's do this. Let's take a picture, anyways, and then let's do the no weight IR weight.
Yeah.
Let's do the no weight IR.
The compress is going to blow through it.
Let's blow right through it.
It's going to blow right through it.
Oh, look at that. All right.
No, that's a good thing.
The two of us were eating our words.
Well, it must be just the interlock coils.
Look at that. Yeah. Fibers. Actually, it does speak to a really nice thing, I'd say. I will take one more, just for more long-term inclusion, of course. But I will say that fibers on coils. Why don't you give me your thoughts on coils with and coils without?
I prefer fibers.
Yep.
Coils are not, for the most part, not mechanically occluding.
Yep.
They're creating thrombus that's going to occlude. Although there are some technologies out there that are trying other things, but my greatest experience is with fiber coils, and that's my bread and butter.
Yeah, I agree. And preference of why I tend to use these over the soft coils is because these have that fiber, and I think, this is a good example. Both of us thought we'd blow right through here. Yeah. But obviously we did. It's nice. So we'll go in here with one more coil. Actually, this is a soft. So let me see what you got over here.
So you want to
2.1.
Yeah.
So just as we're talking about fiber and no fiber.
There's no fiber.
No fiber. Yeah, let's go with the one.
What happens when you don't have any fiber in your diet? You get hemorrhoid.
I think you just came out with the next, next coil commercial.
Well, so Boston, they're going to have a whole new line of foils that are hitting the market soon. So they're going to need some slogans.
There you go. So following this, right? So let's go back and review our previous set imaging here. We were right at the bifurcation. When we're looking at this, it looks like we've gotten the dominant two vessels that are supplying us. Are there some other small branches? This comes up all the time. Should you try and chase down these other tiny branches that are more in the central portion of the rectum, if you will, not on the lateral walls? If they were larger than this, or there was flow down to the cushion, absolutely. But in someone like her, it's not. You're more likely to cause harm and perforations to be going after those things than you are otherwise. And some other cases where the arteries are much larger, absolutely. I think I'm going to put this on roadmap so you can see this, just the coil roadmap itself as this comes out. And see how nicely that'll coil easily. Give that a little push there.
There you go. Nice.
Yeah. Okay. And
so,
then
technical question for you. If you had the normal anatomy, or the most typical anatomy that you see, where there are anterior and posterior arteries on both the right and the left, do you use an oblique to catheterize those? Because they tend to overlay on top of each other in the view?
I would say personally, I'll prefer to do everything in this projection if I can. When you do everything in this projection, of course, it allows you not to have to move the C-arm so many times.
Yeah.
So that's nice. That's our completion run here. You can see we have great, if you will, diminished vascularization here towards the rectum. But I tend to work in this projection. It's fairly obvious to see. Now, if I'm on one side and it's my last vessel, of course, then I'll go to an oblique projection and look for something else. But you can see here, this is what we'll typically do. In a case like this, without a large middle rectal inflow, we won't typically examine or look at the internals.
Right.
I'm taking out that true select, so say goodbye to it, all right.
So we're at the point of the case where you're taking out the catheter.
Yep.
You're going to close up the artery.
Yep.
This has been, the cases are taking us about 35 minutes or so, 40 minutes.
About 35 minutes, yeah, 40, yep.
So just to point out how simple these cases can be, once you get used to them.
Yeah.
So to come in as a patient and to have a case like this where all you're doing is get a single puncture in your groin area, and all you're feeling really is the lidocaine shot.
Yep.
And then to have your hemorrhoids treated 40 minutes later without feeling the pain during the procedure. Really remarkable.
Yeah, it's really unbelievable. So I think this procedure has really come a long way, and I think offering it with really such high success rates, as you know, published, now over 90% consistently, compared with other therapies like banding with success rates that are probably, 20% lower, or may require multiple treatments. It definitely has become very desirable for our patients.
And it'd be interesting if there was a study that did a kind of a quality of life survey and compared banding to Hemorrhoid or hemorrhoid embolization.
Absolutely.
How that would turn out.
Absolutely. Laurie, thanks for joining today. We'll close up here and look forward to seeing you again.